Absolutely.
I'm going to go ahead and
Yeah,
record and send you the link. And I want to
sure.
share with you, by the way, how do you spell your patient's name? Is it Juri?
Yeah, that's jury. That's right.
Okay. So,
Yeah.
first of all, can you share with me how she found out about you and how found out about Vivos or DNA appliance? How did it all
I
happen?
think she found out about me through a friend. She had gone for some health resort, and one of my friend was talking about it, and she was like, I'm looking for someone in the region who could do it. So I guess she recommended me that, I've been Vivos trained. So yeah, that's how she came to me.
Well, that's excellent because I want to make sure that the
Hmm.
patient is seeking the treatment and their outcome that the patient desires is more than just, I want a bigger mouth. Because she asked for six
Right.
months in the face, she asked for. And when she came to see you, what was her chief complaint, the biggest thing she wanted addressed?
Her biggest complaint was that I'm not happy with my smile.
And does she tell you what she's not happy with?
Yeah, she said that, it looks narrow. The jaw looks pretty narrow, and she has that gummy smile.
Yummy. Okay.
That is her complaint. But her mom said that I do know that she has a narrow jaw. So I was like, okay. And then, of course, when I took the entire history, I did sort of say that, it all started from the tongue, and she's a tongue tie, and there's a breathing issues and all of that. And then they got really, really convinced to go ahead with the treatment.
Got it. Which is why they're in a
Yeah,
hurry, right?
right, right.
Expectations are best. They're flying from another country to see you. This happens to me every day. And once you put the team
Okay.
around you,
Yeah,
then you become the voice of authority. I cannot wait for this to happen to you guys because
thank you.
really it's not that
Yeah.
difficult because everybody's good at what they do and what you really are going to find out about this case. And if you're, I mean, I cannot have the patient on the call, not until I get my license over there, which Nader is working on.
Uh,
But you can make the recording
right,
available to them because I'm consulting.
right.
The main concern about this young patient, which is she's really young, is
Right.
she's already starting to suffer from digestive issues and she has a reservoir of adaptive capacity elsewhere that she's running herself to the ground. But the fact is, her
Hmm.
body is nutritionally suffering and sleep-wise suffering. Both of those two are
Right,
indicative of dysautonomia, which you're familiar with. You guys do a lot of
right,
this. I know ECMO is huge on this as one as well, upper cervical
right.
stability. Now, I'm going to go ahead and focus a little bit on that. And I just want to caution you that once the appliance goes into her mouth, it's that much more important for this patient to have an attention from a chiropractor that can address the pelvis and the neck,
Right.
not a physical therapist at this point, because the orthopedic rules, if she's not orthopedically stable, you can repattern
Hmm.
muscles. Muscles are holding her in that pattern because orthopedically and neurosensory wise, she's not able to do what it needs to do, which you're a huge
Hmm.
part of, by the way. And the good news about our appliances, they're removable, meaning that if they're not,
Hmm.
they're supposed to, they're not parked in her mouth. They don't have to be.
Right.
Sorry, told me. So I cautioned you about that one.
Yeah, I know that's
So the
okay.
muscle spasm that's kind of like bringing it up to the next speed is the muscle spasm that she reported and abnormal posture. They're both going hand in hand, but the one we're going to adjust first is going to be so she makes sure that the tone is safe. Here we go. All right, Tala, sit down. And then the headaches and the sleep deprivation. So the headache, I want you to get a little deeper into it. Does she have headaches that are starting at the back of the head, bilateral side of the head? When do you know anything about the nature of that, or you haven't asked?
I did take a history. I think she has an headache on the side of the temple.
Mhm,
So when I also did her investigation
mhm,
on clenching, she had slight pain on the temporalis.
mhm. Okay.
Yeah.
So you think, but it's not like there's a trigger for it, like it starts at the end of the day, or she wakes up with it, or any of that.
No, she in fact said that she used to have all these issues before, but then ever since she started doing this holistic treatment, holistic lifestyle,
Okay.
uh,
Well, holistic or stuff.
she
Whoops. Okay. Okay, I want to make sure we're still on recording. Yes, we're still recording. I know that you might have lost connection. All right, no worries.
Sorry, I lost you.
It's totally fine.
Yeah,
I was just
yeah.
thinking, what are the holistic stuff that she has done that you're privy to?
So basically, what she said that, she's gone to, I think Florida, there is a place called Hippocrates,
Hmm.
wherein they give you a certain diet, certain vegan diet, all of that. And that's how she started feeling better. But then she had like a lot of problems. In fact, her mom says that she, among all the kids, has the highest amount of problem in terms of digestion, in terms of allergies, in terms of she just has problem in healing overall.
Hmm. How long has this been a concern with this child that you're aware of?
The mother says ever since she's born.
Oh, wow. Birth trauma.
And when I asked her the history of breastfeeding, I think she did say that hardly like for 4 or 5 months.
Mhm.
So, which is why precisely I said that, I do suspect something with the tongue. And then we came with the diagnosis that she does have a tongue tie. It's a grade 3 tongue tie though, because it's more like posterior tongue tonicity is not right. So yeah.
So with the tongue tie, I'm just really giving you a broad overarching. There has been a lot of misinformation flying around, and I know there are being terminologies put in, taken out. This is as of
Mm,
now. The tongue tightness has been really misunderstood in essence.
mhm,
It's more like
mhm,
for the iceberg. What really goes with
mhm,
the tongue tightness is the constriction of the rest of the cranium, especially the dorsal,
mhm,
which I'm going to point out.
mhm,
I'm going to caution you, and I do this all the time with patients. With this particular case, doing the tongue release or any of the tongue therapy to the other than just tongue posture, you gotta prepare the body for all the tongue therapy you want to execute. Because when she doesn't have a stability in the upper cervical, the 30-degree lordosis, when she's limited in the lateral movement, atlas is off, cervical spine is off, the orientation of the spine itself is off. What will happen is you engage with myofunctional therapy and you want the tongue to have that posterior suction, and they're not able to attain it because the tongue has 5 cranial nerves attached to it. And when you don't have stability in other part of the structures as bipedal, the tongue becomes that organ. So when you don't have stability in the occlusion, tongue is your occlusion. When you don't have a functioning
mhm,
diaphragm, and we have several diaphragms, pelvic diaphragm,
mhm,
and her pelvis is not underneath her ribcage. Now the tongue is doing that job. If the neck is not stable, the tongue has the job of stabilizing mandible against the maxilla with every swallow. Well, what
mhm,
happens is now we haven't addressed all the other things that is disconnect. If we are just saying, let's make the mouth perfect and the tongue perfect, the body will not allow it. And I have seen things getting worse for some of these patients, especially
mhm.
that we're not really knowing why they're tongue tied. So
Right,
I'm telling you the category, and I want to ask you a question about myofunctional therapy, who you work with,
right.
and what exercises they do. If you work with one, I would suggest get just a stage one. The first 4 to 6 weeks is nasal breathing, removing inflammation, especially that already she has a lot of allergies, but releasing that vagus nerve, getting some vagus nerve activation. When the cervical spine is misaligned and there's any suspicion about cervical instability, which lack of lordosis will pretty much kind of predisposes her to. I'm not trying to say that she is or she's not. It requires an MRI,
Mm,
motion analysis, but looks like it, that she's got something
mm,
in the neck, the curvature is lost. I would put that on the long list to kind of review because doing a lot of things with the tongue requires to make sure that the stable systems is stable in essence.
mm,
Inflammation needs to be resolved first. Obviously, if you don't work with a functional medicine, I suggest we put that again on the long list. With a child
mm,
that has digestive issues, mapping the gut is not a bad idea. If they haven't considered that, I would suggest that they would look into mapping the gut. Again, I don't know what
mhm,
testings can be done over there, but if I was sent to a functional medicine over here, I would ask for OAT testing, gut mapping, and for fact, I would have a mycotoxin mold test. Because a lot of
mhm.
times, mold is one of those nasty, nasty infections that
Absolutely.
cause dominate. I'm telling you, so many kids have had long-term battle with it, and especially if their immune system is debilitated from inflammation, cycle of inflammation,
Mhm,
they're more susceptible to it. In the same household,
mhm,
you can test the car and the washer dryer and the home and test every single person. Nobody else is
mm,
sensitive but that child because their adaptive capacity obviously is being overspent. So test the
mhm,
child first. Mycotoxins, $300 test here. There's a P-test, you send it in, and there's some really good holistic way of addressing it with glutathione, sometimes even nebulizers. Just rule it out. I would put that on the short and the long list, but treat them also. Yes.
Sure.
And again, when she reports history of headache and congestion, and trust me, I've seen some of those go away when they're getting, like the kid goes on a steroid for a different reason, and all of a sudden storing stop and they're not having headaches. Okay, so they dampen the immune system. That's what the steroid would do. They treat it, but it's diagnosis.
Right.
So the cold sensation, again, more of the things that she reported is pointing to the fact that I believe there's either a thyroid issue or the spine alignment itself, the vagus nerve might be a problem. The fact that she has having trouble adjusting temperature, thyroid might be an issue. And then body obviously is going through some physical stress. Orthodontic treatment, and she had headgears, which has contributed a lot to a lot of that for, you know, the curvature in the neck, and extraction of tooth. Was it a baby tooth or a permanent tooth extraction?
I think it was a permanent teeth extraction.
Okay. And at what age also matters. We probably gonna have to address that. Because a lot of times they have extractions as baby tooth, and I'm guessing the wisdom tooth are still there because I couldn't find.
Yes, they're there.
Okay.
Yeah.
And she doesn't have enough sunshine, or it doesn't have sorry, doesn't get off the screens. You know, that's almost all of us, but just to point out that some of the, you know, sleep transitions, melatonin production, all of that would be related. Not that I'm saying that's the only reason. And you know, a lot of questions that she answered, they're not a yes, they're not a no. It's like, no. And a lot of times, this is why I love this questionnaire and it's perfecting. And I have a new one I will send you that has a lot more about fatigue and a lot more around specific areas, more on functional medicine, getting more specific. When the patients give them a paintbrush to tell me who they are, they will tell you who they are. And when they're not able to tell you where my symptoms are coming from, there's vagueness, you need to really be on it. Like that raises the alert with me because a lot of time people come in with their definitive, I want a straighter face, and they know why. But this patient, and the reason why I'm bringing it up is because there's this overarching layer of psyche over soma. So we have psychological health, we have physical health, and then we have chemical health. All three of them need to be governing for health. And when I see a lot of things that you and I can see on a test, on a blood work, on a urine test, on a CBCT, a home sleep test, those are all from a physical chemical compensation. But what we don't see, especially if she was born with it, is the actual trauma, even prior to birth, that's embedded in the system. And when they're not able to tell you what it is, that means there might be that layer to it. And a lot of times what I've seen is as we're trying to engage with this patient, to get them to the next level, that primitive reflex involvement, the primitive reflexes are the reflexes that we have when we don't have a functioning nervous system. And if there's a trauma before or during birth, that can impact the functionality. And as we're trying to make one area better, they're in a central sensitization. Basically, their nervous system plastically has reverted back to primitive stage, which is why they're tongue thrusting. Tongue thrusting is not just a tongue tying, which is why I said tongue tie has been a tip of the iceberg. When they have a tongue thrusting, that's an infantile reflex. They're reverting back to what they used to do as an infant. When we don't have teeth, when tongue doesn't have boundaries, we are using our face to swallow, right? Our facial nerve is a huge part of it. And as we are neurosensory wise, somatosensory, we develop more and more. We're supposed to be integrating those reflexes. And if they have not integrated, she's still in the brainstem, it's going to be a little bit more difficult getting her to the next level. Recognizing it is the only thing that we need to recognize, because we can at the same time pair up with someone who is the practitioners I work with are MNRI, motor nerve reflex integrations. There are different techniques of exercises they can prescribe to get the right and left together, get them from a brainstem to a midbrain and to the frontal cortex, because really breathing should be a subconscious event. And when their breathing is suffering, and it is related, in fact, to traumatic patterns and reflex retention, if we don't address it, the spine keeps moving back. A lot of these emotions are actually held in the spine. I will send you a really good chiropractor I'm starting to work with here. Their work is all around the spine and trauma. And I just don't want that to be overlooked. When I see signs, I'm like, okay, let's put that on the list. and ask mom, was there a traumatic birth? Because she had a lot of issues with, I mean, the demeanor, the posture tells me there is more to the story potentially. Just want to make sure this kid gets what she needs. And sometimes releasing those reflexes, by the way, the tongue's a huge part of that tip of the iceberg, is what they need to go from that ADHD, autism, a lot of those dyslexic behavior. You give them the best route for care, not that they're in holistic, just mention it, especially when Atlas continuously getting subluxed. I've seen this over and over. And I asked the mom, did she ever crawl? No, she never crawled. Okay, so this kid doesn't know left, doesn't know right. So again, I have all those resources. I don't want to overwhelm them. Let's just, if the first 3 months, the treatment is not working, she's not able to attain the tongue posture, if she's not able to get through treatment, halt, we're going to revisit. Let's get other things involved. And I really want you guys are my hands and feet now to be at the next level. You're the one integrating all kinds of physical medicine and neural reflexes and neurology and brain waves involved with your treatment, because every dimension would change in the cranium through the mouth, which really this box is the representation of this box. Everything we do in the mouth is going to inevitably change the neurology. So we are neurologists, in fact, and I just know that you guys you in particular have embraced it. And now that you have a new clinic, I know it might just make sense to work with those, especially if you work with children, occupational therapist, neuroreflective specialists, definitely work with them. Some of their work is actually done online, which is really amazing. So with
Sorry?
Some of the?
Sorry, I lost you last sentence. Some of the?
I said some of the, where is it? It's recorded. You can listen to it later.
Okay, sure. Yeah.
I just said it and I forget it. So I'm looking at, like I said, when I'm looking at this child, their posture and demeanor, like I said, you become very intuitive. You see more and more. When you look for it, you'll see it, especially the way they're holding their posture, the neck, their hands like clutching. Their body is not expanding. They are converging. That's emotion.
Right.
And reflexes, neuroplasticity, their body reverting back to central sensitization, like going back to trauma. That's when Dr. Stephen Olmos teaches the black and white sensitivity to scratches with ulnar, and goes, they're reverting back to primitive reflex because, their body has not dropped that manual brake, haven't integrated reflexes. The opportunity hasn't been provided. The environment has been so hostile. I mean, in any one of them. My daughter has, and she's completely been ADHD and all that. And yes, tongue tightness, just like, eating Oreo cookies and brushing your teeth at the same time, trying to treat a child at 4 years old with all this trauma from orthodontist. Honestly, I cannot even begin to tell you. And the headaches will not go away. I mean, they start, and she probably had them when she was young, but now she can tell you about it because they're going through life in fourth gear. So the pressure causing the headaches. This is where I think I'm going to just spend a minute over here. She thinks it's food intake. Let me tell you what my suspicion is. This cranium, the presentation of this cranium is not moving. The spinal fluid, venous return, CSF is not flowing between the head and the body.
Doc, sorry, I have to actually put my phone on charging. It's about to die.
Okay.
So is it okay if I just sit in the car and I'm going to call you back like literally in a minute?
You know what? I'm going to pause the recording. You join in when you're ready, okay?
Okay, done. Perfect. I'm sorry about this, yeah?
Hey, absolutely not. No worries. Chill.
Sorry, I'm just going to catch you in a minute.
Okay. But are you going to be okay driving and listening to me?
No, I'm just going to be sitting in the car. I just need to plug it in.
I don't want you to be driving. Great. Why don't you just
No, it's okay.
plug in when you're ready. Start. Okay. As you were getting transit, I was looking for that podcast to just send it to you, listen to it. It's really profound, kind of explaining to you pain and trauma connection. And especially when I see younger people born with symptoms all along, colicky baby, like all of that just means she's still not done processing that. It really gets to that next level. And when you're seeing tongue signs, again, this is how I'm really trying to set up the doctors that I work with, separate from the dentists that only tongue tie. It's not just tongue tie. It's like umbrellas and rain. Causative relationship, or is it just a correlation? And tongue tie has been blamed as a cause, and narrow maxilla, they're symptoms. Tongue tie is a symptom of unprocessed trauma. And again, I'm not trying to sound esoteric, but everything is vibration and energy. And when we haven't processed that, we're going to have a deeper conversation here when you're in US or when I'm in Dubai. But when the body hasn't processed the emotion, that vibration will in fact restrict the fascia. That's just fact. Now, it could be physiological, could be physical from a contortion, but it could be all of them. When you're suspecting that there is that psyche element, which all of us do, it behooves us to address that. And I've seen, I mean, you listen and see the works of similar practitioners in other areas we're not, you would we would respect the body a lot more in order of things to be done. And this is my opportunity to get you guys acquainted with those level of thinking, because it's easier for me to teach someone who's wanting to learn rather than a dentist that only sees the tongue tie. It's really just, it comes to that. And allopathic medicine is just saying, here's the thing that you see and here's how you fix it. That's dentistry. Here's a hole in the mouth, here's how you fix it. We don't ask the question why they have a hole in their mouth. We just have, it's gone along with everything else. And this is how our treatment is different. I try to explain to Nadir, how am I trying to set the pace differently for what we're going to do with these appliances? And I can tell you, Dr. Rashida, case after case, I have the most challenging cases coming to me from England, from other countries. I actually have one flying from New Zealand now. It's like, why are these people in airplanes coming to see you? Which is awesome.
Yeah.
Because they want an expert. They have bypassed everybody else in between. And I truly want you to be the expert, because you guys are at that level of receiving and processing. And I don't want you to just say, oh, we're expanding you. That term I'm trying to sponge out of, completely take it out of our vocabulary. We are doing a cranial neutrality. We're getting their body to neutral, and that starts with the fascia, the spine, cervical spine, and all of that. So thank you for letting me take that opportunity. I'll text you the website, and then you can find a practitioner. But again, on the short list, it just behooves you to acknowledge it in the beginning rather than later on saying, well, we have to go check that. Learn from my mistakes and other people. Make your own original ones. The chiropractor is a must, absolutely a must. And I will try to find, if I can find the right chiropractor for you, that some of these are global trainings, which is easier to do in outside the US. And I will give you those resources. And once we build a team, we don't have to reinvent the wheel. Once we have all of those 5, 6 different practitioners around you, you call them and say, this is what I need you to check. Right now, we don't have that. We're building the ecosystem. But once we have it, you have functional neurologists, you have functional medicine, you have neuroeffects specialists, you have myofunctional therapists who knows what they're doing. And you are the expert in the oral cranial orthopostural aspect. And then you know what to hand it off to the PT and what to expect from them when the patient comes back. You're the quarterback, basically. So as a quarterback, you're going to need to know the whole 9 yards. And that's why I'm going to, this is why I love this questionnaire that I built, because it allows me to walk through the patient journey. So the fact that she had headaches from pressure, and I tell you, when there is pressure, increasing headaches, intracranial pressure, it's because of the lack of drainage of the spinal fluid and venous return. When there's discrepancy, the major arteries of exchange of blood, oxygenated and deoxygenated blood, and all the fluids, lymphatics and CSF, and nervous structures is which some are traversing between C1 and occiput, C1, C0. So if atlas is subluxed and that curvature is impacted, upper cervical is not in the proper order, it will impact the functionality of all of those. So the return of the venous is going to be impacted, which if the blood is not returning, it's going to cause some intracranial changes, and that can induce pressure on the brain. And when the lymphatics is not draining, the toxicity can build up on the brain. Just metabolic alone. If she has mold toxicity on top of that, that can cross the blood-brain barrier. Lack of sewage drainage, for lack of a better term. When the irrigation system is not properly functioning, we have too much of toxicity, bad storm. Actually, they did a study on autistic children, and that's exactly what they proved with MRI. With children at birth and 3, they were expecting genetically be autistic. Remember, autism is a symptom, it's not a diagnosis. They said, well, it seems like they all have this fluid building around their brain, the CSF. Yeah, because they're not draining. So they're structurally off and they have too much toxicity, which now they're relating that to vaccinations and heavy metal toxicity and what have you. And mold is a huge one. But in all cases, a perfect storm, when you open up that drainage system, allowing that fluid to exchange, you're already giving them a head start. Actually, there's a lot of people that work on autism and ADHD and dyslexia non-medicinally. What does that tell you? We're missing the structure and the, biophysically, we're calling everything just genetic. Epigenetic, I would say, but nonetheless, no, this young soul, why I keep telling you about that, because that set the stage for me. And I want, if the parent listens to this, or the child, you see how the head is tilted to one side? When the head is hanging to one side, that's atlas being subluxed and sphenoid is off. So out of the gate, I know sphenoid is not in the right place, atlas is not in the right place. There's drainage issue. Period. End of the story. Now we need to get into it deeper. How big her reservoirs are, the conduits are, the nerves exiting from, and the vessels. With a teeny little girl like this, I would say probably not big, and that's why she's suffering, because the structure has been bent and never unbent. At 20, how old is she again? She's not 24 yet, is she?
No, she's I think 18 or 20.
Yeah, the spinobasilar still is not calcified. I mean, spongy. It's still cartilaginous. So working with a good SOT manual chiropractor, someone who's really I want him to be trained in intraoral aspect of things, going into the palate, moving the sphenoid, moving the vomer, moving the palatine. This kid needs some help in that regard because there's a dent in her skull, in the base of the skull. Again, I'm going to devote that potentially to a birth trauma or how she was positioned in the womb or something that happened afterwards. We're just going to get a little deeper. So what I do see I have the chimera here, the side that is like the eyes are converged closer to each other is on the right side. So when you have the appliance in your hand, you will see that each one of them has a block on one side. And lower one, usually I remove later, but the upper, the way I decide where to put the block on the top, there's multifactorials. It's like a Rubik's Cube or a combination log that I solve. But the first thing I look at is the zygomatic arch. So the right side, the eyes are converging closer to each other. So it tells me that the sphenoid is shifted that way. So if you want to stimulate and bring it to the middle, we need to stimulate it from the maxilla. So that's how I decide where to put the block. That's the first out of the gate, not the definitive. This could be very well a cranial lesion, or it could be a distortion in the tentorium, the rest of the dural tissue, which is basically from trauma. If somebody hits you right here, your skull doesn't break, thank God. The sutures get more jammed and over jammed on one side, which will impact dural tissue that's connected to those sutures. As the temporal bone gets locked up, it will in fact move the sphenoid wing, which affects all of those physiology stuff that I told you about. Now, was this just a cranial lesion, how she developed, or is it a gravitational force respond to some other impact or something else? I wasn't there. I'm just examining the evidence. There is in fact narrowing of the face on the right side. And that chimera is regeneration, if the patient asks, regeneration of the entire facial structure from the right half and the left half of the face. And then I look at the ear position, the ear that's hanging outward or more, like if you're looking at this picture, the left side appears more direct, more developed. The right side underdeveloped, zygomatic arch is flat. So she does not have a disclosure of the canine and decompression of the skull on the right side, which is why I would like to give her a reference to be able to decompress her. Again, I go back to the real face and where things are. When she looks at the mirror, it's like that. I don't like the way things are. That is not making sense. The right side, you see how it's dropping? That's where I got the block in. So when she wears the appliance at night with the block, she does not wear the lower with it. I do not ever have the patient together.
She doesn't wear the lower?
She wears the lower during the day after she gets the clearance from the chiropractor.
Okay.
The reason why I'm telling you this is because what I put in the maxilla is to change the cranial structures in a non-weight bearing. I do not want to load the spine when I'm changing the cranium. I put the lower appliance with the block and it has an activation key because I want to orient the sphenoid with the occiput and cerebellum, because all of the sensory information from sphenoid's wing, which is eyes, literally just the eye sockets, and goes into the temporal bones from the vestibular system, from inner ear, balance center, even hearing sound itself. Close your eyes and try to balance yourself, right? You put your teeth together to just find the sense. If you're standing on something unstable with your eyes closed, you get that from your mouth. So we want her mouth to give cerebellum a better sense of who she is. But if she cannot ground herself on the right side, in the foot or in the mouth, we want to correct that as the neck allows it. Anything I put in the mandible is in an upright position, and I'm very cautious of when they're wearing it. If she's not stable enough to wear it, as far as a chiropractic goes, then we're going to have her wear the lower one at night just for the developmental sense, because I use the lower appliance and upper appliance both for two reasons: correct the structure and alignment of the head to the spine, and correct the correlation of the bones that put those things together, the occlusal suture in the cranial neutrality. Make that maxilla neutral as humanly possible, given that there's a dent in the SBS, and get that mandible to be neutral against that maxilla, which is an upright position. We have mandible and mandibular teeth to allow us to walk through space. When the kids walk, when they get first molars. First molars land your skull in the proper orientation of the eyes so you can walk through space. Without molars, we can't do that. So if she does not have the reference on one side of her mouth, she cannot orient herself. So we're going to give her that false reference with the lower block. That's whole unilateral bite block system I'm adding to this is the part Dr. Rashida has not been a part of the appliances before, and I've inaugurated it for about 1.5 years now, and now it's going to be ongoing in the future. That is how we're going to be using our both technologies. So DNA is not going to be a flat appliance anymore. It's going to be a lot of changes, and you guys are getting first-hand version of it. So again, you're the first in the region. Just, I think if that does not make you feel great, because you're really awesome. You guys all are. I'm just really amazed with the quality of these doctors that Nader has picked. So looking at submental vortex, just a confirmation. I'm showing you a few of these just because I want you to know what we're changing. We are trying to get this box, the actual cranium, to go from the state of parallelogram to equal on both sides, meaning the ears in pitch, roll, and yaw are getting the same information to the brain. So temporal bone position, the most important part of this, hence why you need to have an SOT chiropractor, sacrooccipital, neuroreflexes specialist. Temporal bones have a lot of information with them, and when they get locked up, they will lock the entire system. To unlock the skull, we need to focus on that. And the focus is get that dural tissue release and get that temporal bone oriented. And that's really where the mandible want to be. Mandible does not follow the order of the teeth. As a matter of fact, if you look at people when they talk, there's no contact in the teeth. When they were speaking, exhaling and speaking, there is no contact between the teeth. And unfortunately, dentistry taught you and me to get the condyle within fossa and put the teeth in there. Let me tell you what's wrong with that philosophy. And that was one of the reasons why, again, some of the institutions didn't make sense to me, because position of the temporal bone decides where the mandible is hanging off the skull and how the body used that information, not the teeth. The teeth need to match that. So I don't even engage with the teeth until I know the temporal bones have achieved neutrality. And if this is in fact an ascending problem, that need to be addressed first, which is exactly the case with her. So she may have been born with an asymmetrical skull, became an asymmetrical spine, and an asymmetrical pelvis that's oriented to one direction. She's referencing one side of her spine from bottom up, and she doesn't know how to actually get to the other side. Is it reflex? Is it cranial distortion? Is it pelvic? Is it just the foot position? We need to work with other professionals to know those. All I'm seeing is the surface, like the tongue tie. What else is in there? And if you have the tongue suction, I'm just going to go ahead and show you. When you have the tongue suction, if the tongue on one side is slipping off, just know that that side is completely sympathetic, which means that's the side she has no idea how to, that makes no sense to treat the tongue. The tongue will tell you what the problem is, will point to it, but it's not the root cause of it. And that's really where I'm trying to really hone that message. The appliance we give her is to give that reference to the cranium so that the tongue has a chance. But until we have the structure properly aligned, we cannot get her to that level of functionality with the tongue against the palate. Does that make sense? I know I'm giving you a lot of information you probably are processing still, but I just want you to know why you have the appliance in your hand, why there's a block in there. The block is going to give her an artificial reference, is non-weight bearing, so we can start working on this structure. But buyers, be aware, there is a contortion in the temporal bone. At some point, the body will not let us move or activate the keys. So for the beginner, I will allow her to have the appliance in her mouth, exercise some nasal hygiene, like Clear spray. I love Clear, it's xylitol based. I have a couple of recommendations for nasal strips to get her nose to work at night, get better flow through. These are all band-aids, just to get her aware of her tongue posture at the roof, the tip of the tongue at the spot, start working on swallowing and being aware of it is more than enough. You will not be able to achieve all the milestones with myofunctional, and definitely I would not recommend engaging with the release until we have addressed the reflexes and the cranial structure first, especially with this one. So let me get to the good part. I'm so proud of you for removing that tooth gel, and yes, she had upper bicuspid extraction, which means she has that cranial distortion as I anticipated. I just, this is a lock in the cranium, especially this stainless steel ones. The cranium hasn't been able to move. And probably she could tell you her headaches maybe have gotten better after you removed that. I'm not sure if you had to report or not. But yeah, the Eiffel Tower. She does have the Eiffel Tower. So you're like just itching to get the release, even if that's what we're going to do. I would say if you have laser, do you have access to laser, any kind of laser? Okay, so for Dika, which one do you have? CO2?
I have, no, not CO2. I have
Erbium YAG? And the YAG?
the pen laser, the pen,
Oh,
the pen device.
Those are, yes, I know. Those are
The soft
electricity.
tissue.
Yeah, definitely. I would say if you don't, I mean, I don't know if Fatona has a presence over there or Deca. Those are my two preferred ones, but Erbium YAG, or ND YAG and CO2 are the three. Fatona and Deca are the two companies that I have worked with, and I love that. And actually, if you ever want to invest in getting one in your clinic, it does reduce a lot of inflammation in the palate. You can use the laser for many other things. This I would do in several stages. And and releasing some of the restrictions in the tongue might be necessary, but just one stage, not through the full blown release. Do you do any tongue releases, Dr. Rashida? Have you had trainings with that?
I have not had like a formal training, but I have been doing tongue tie release because I have attended like few of the courses. I've not like in all of these conferences that you go for, so I've taken a hands-on course for that. So I've taken that training.
I'm probably going to be bringing some training around tongue release over there, but I need to have the right laser. I've done several different kinds of laser, and I love CO2 because it cuts the surface, doesn't deep. But NDIAC has its own advantages, and the energy of the laser and how it actually changes the molecular level, the fascial structure, instead of releasing it, we change the chemistry of it. So those are trainings that I'm inaugurating here as well, but I would personally will bring it out to you. And very, very conservative, by the way. There's less of a cutting, more of a structural stretching of the fascia, because fascia will just guard itself again. You have more rebound and restrictions, especially when we suture it. I used to be all huge on suturing, and then I was like, whoa, range of motion completely decreased right after we suture it. Trust me, I did that on my son. I'm like, these are the things that we learned, right? Same people who told us posterior tongue tie told us to suture. So bunked, debunked, not doing that. Let's just do it better. That's why we call it practice, right? So I'm showing you the slides that are telling us what it is we're trying to do. Where the cranium is not neutral is right in front of you, right here in the mouth. So the position of the maxilla, you see how I have a horizontal line here that tells me where the maxilla is oriented. You see how this canine is touching and this one is higher from it? So that maxilla on the left side is down and is higher on the right. You see that? And you see how the teeth are completely tilted inwards? So the things that you're trying to achieve, we do not expand mandible. I always put an appliance in the mandible, never gone without, and never had the patient wear them together. I make changes in each one of the parts of the occlusal suture separate from the other one. With two things that I want to achieve with the lower. First of all, I want those teeth to go into 90-degree on the angle and the alveolar bone, zero torque. Right now they're inward torque. Okay? That's a lot of tongue. And the lower appliance will do that. I will show you some of them. You'd be amazed how much when you activate the keys, it literally just opens the mid. There's only one suture right here in the mid symphysis. Whether or not that opens, I'm not going to say yes or no. I hate those terms, growing bone, none of that happens. It literally uprights the teeth, increase the oral space so that the teeth, in fact, molars can get into zero torque. That's first. Increase the periphery, right? At the same time, we're making changes on the top by putting the internal maxilla into external and basically neutralizing the cranium from the mouth. No overbite overjet. So when there's no overbite overjet, there's a pitch issue, right? We want the half millimeter. So maxilla is sitting in mid pitch that comes from the neck. And we're going to show you that right here. Pitch. That's a pitch issue. It's got this woodpeckers, And there's this hump. Remember, I said the upper cervical is not stable. You have got to have a good chiropractor on you. If you can find you an SOT and an upper cervical, I would start with an SOT, sacro-occipital chiropractor. Dr. Rashida came in here, met the chiropractor. I will make sure when you're here, you meet him as well. Send me an email reminder to make sure that I organize that, and you will learn.
Is it possible? Sorry, is it possible to get the training from the chiropractor? I would really like to learn.
As a dentist, I have been trained to do a lot of manipulations inside the mouth and doing cranial motion, but as a dentist, that's not our area. I learned it to know what to expect. It's outside of your scope, and you can't. But what we can do is training a chiropractor for you. But I want you to experience it as a patient so you know what to expect. Unfortunately, you can't manipulate pelvis, you can't manipulate neck, but we have to be in charge of the tongue. It's like, you know what I'm saying? You see how it's like all intermingled and yet there's no escape. We'll get it done. I mean, it took me only 4 years to get to this point, but I'm shortcutting that for you guys. Just saying, let's set it up properly, because you will be farther ahead if the body doesn't fight you, which clearly rotated shoulder. You see how one hand is in front of another? The rib cage is rotated, and she doesn't have a pelvis underneath that rib cage. So she got that posterior. There is no pelvic activation here for diaphragm. So breathing diaphragm is not working. You know who's doing the job? Tongue. And tentorium, which is the other diaphragm, they are also restricted. So this child, and she's overusing her facial muscles to attain this posture, which is why she's got that temporalis overactivity. By the way, when temporalis and sternocleidomastoids get overactive, which in her case they are, look, about a whole half a foot, her head is in front. The sternocleidomastoid does a few things when it's overactive, trying to get that posture, restrict the flow from here. That's just inevitable. That's going to happen. And she continues swallowing that, but she's going to have a thicker band of stylohyoid ligament here, which even restricts the flow more. And the Eagle syndrome is in the making. The other thing is when you're overusing temporalis to attain this position, it would lock up temporal bone, which causes everything. Because by the way, when temporal bone gets locked up, you know what's underneath of it? Temporal lobe. Temporal lobe houses the amygdala, emotion center, anxiety. Like relieving this cranium and getting it to move can relieve some of that anxiety. As I'm talking to you, it's like, I just want to do it right now, all of it. Because trust me, my daughter is exact prime example of that. And she's 12 years old in the growth period, you know, and she constantly is losing baby teeth and trying to stabilize the system. She's just literally like my daughter. You're going to see, like, you start looking at it, you see, oh my gosh, it's everywhere. Like you see people are locked up on one side and they're overusing the other side and using this side to breathe. How can I bring this system to neutral? You can't by yourself, because gravity speaks. Pelvis, neck, all of that needs to be addressed simultaneously. It's like a tube, dural tube. Like you have the other end and the chiropractors have one end. And once we get the orthopedics aligned, now let's talk to the other people, the neuroreflexes, fascial, sensory information. You know what I'm saying? I really don't know how to give little information. I don't. I'm sorry, it's coming out like a fire.
No, I absolutely love it, really.
Okay. Well,
by the way, that reminds me, I have not got the recording of the last session.
I will send you both.
Okay,
I will send you both. Okay. But I'm covering a lot more detail this time than I did last, and I had access to your CBCT. By the way, I told Nader I would love to have a center that take a full volume. This is as much as I want. I want the occiput. I want to know what state. I want to be able to track the dura on all the sinuses, all the sagittal, transfer sinuses, everything on a CT. And if I only have this, it won't work. So I want to make sure our records are taken properly with the proper machine so that I'm not missing anything. And that will be our standard. So I'm working on that with Nader. So
my clinic, the clinic that I'm opening, I'm having a FOV of 13 by 16.
So you just field of view, and if we can work on a laser, you be golden, girlfriend. I tell you, I'm looking at how she's like her airway, not necessarily small, is it? Collapsible, 100% collapsible. Here's why. She has absolutely no curvature in the spine, and C2 is slipping in front. Bad news. When C2 slips in front, there's ligaments that are attached from C2 to C0, and C1 kind of like anchors that acts the dents right there, and she's literally wearing out the ligaments of the upper cervical. This is a CCI, craniocervical instability in the making. This kid is headed that way. And when those ligaments get loose, now she's going to have cracking and popping in the head and all this hypermobility. And all those structures controlling nervous system, blood flow, and everything 10, 20 years down the road are going to be impacted. And she's going to have tinnitus and vertigo and all of that because there's instability of the nervous structure traversing between C1 and the head, which now she needs therapy for something we can avoid. I mean, I cannot tell you, you are the saving grace for this patient right now. You are. I mean, you are the one who says, let's take a look at the structure. And I'm so thrilled that you just like, no, I'm not, I'm going to get on it right away. And I'm glad, but just understand a dental appliance is not going to do it alone. It's a huge part of it, but there's a coordination to be done. Arc of the face needs to meet. She hasn't met the arc. I just did a little quick and nerdy version of it. I think I have measurements of your CT. I'm going to go straight to it in the interest of time. So the measurement of how much she has missed the AP, and with the bicuspid extraction, the problem was right here in the cranial base. You see that? The cranial base was bent in hyperflexion, and that's why she didn't come forward, because maxilla, like my dog, when I walk my dog, maxilla is like the dog, vomer is the leash, and owner is the sphenoid. If the sphenoid is torqued like that, it will, like if my leash is just this little, I will pull the maxilla backwards. She's about a good 10 centimeter behind the arc because the leash that's in the hands of the sphenoid has been stuck up like that. So there's a vertical strain, potentially a vertical strain. That's why I want to have an osteopath look at it. And look at the position of the atlas. You see how it's sitting in a pitch like this in an extension? It, first of all, just the body of the atlas itself, slipping off within the frame, within the ring of the axis, the dents, and correlation to foramen magnum is introducing a lot of her symptomatology. If this neck has a better chance to be attaining a 30-degree lordosis, so a lot of her symptoms should be resolving or getting better. But she cannot do that until the mouth is supporting her like that. So breaking the occlusion and getting her a reference that allows the neck to get there is the first important thing, which is why I put a block also on the lower. And I love the kinesiology testing. There's other metrics that I'm trying to incorporate in using it so that you know for a fact you're in the right place, supporting the skull in the right place. 10 centimeters, she needs that. And the appliance I sent you has the screw, the 3-way, that as she wears it, she only activates the keys once every 2 weeks for a full turns a quarter, or half a turn every week. If she does not, in the beginning, we go through the grunt, what I call like just getting it in there and getting things moving. I'm okay with every 2 weeks. For the first month, I don't even want her to activate it at all. Just get used to wearing it and work with the chiropractor, tongue awareness, breathing, nasal function, reduce inflammation. Look, there's a fire in this house. We're not building your floors right now. We're just trying to get this inflammation under control, get some vagal tone. Then we're going to go through, let's say, the construction phase. So the appliance has several purposes for me. First, aligning the cranium. Second, aligning the teeth. Not moving them, aligning them. Third is allowing the nervous system to posture itself to allow the neck to function. So there's multitude, and also neutralizing and developing the arch. You see, I don't call it expansion. I don't want you to call it that either because it's misleading. Arch development. We need to develop the arch to a neutral cranium that a body allows. And once we have that cranial neutrality, now we're going to intercuspate, and inter-arch relationship should be in a neutral as well. But we have to have a stable neck first before we can make this part work. If the neck is not neutral, mouth cannot be neutral. Period, end of the story. So the first phase, break the occlusion. Give her a reference for the cerebellum. Get her body to know where to land the mandible without that pathological occlusion of the teeth. The occlusion of the neck, occlusion of the teeth. Once we don't have that occlusion anymore, and once the cerebellum know where to land the mandible, you'll be amazed. The mandible goes shift to one side and goes, yeah, I don't want to go back there. Come on, Tella, come on. She's just trying to jump. Okay. I don't want to go back there. Now we're going to develop the maxilla to that position. So the first thing is get the body to tell us where things should be. And then, right, it takes a good while. I would say sometimes 6 to 8 weeks just for that phase alone with the block. No turning it. Do not turn it. Just get the body to get the memo. Get the tongue to know where it's supposed to be. Then we're going to get it to the neck. During that time, the chiropractor is going to stabilize pelvis, stabilize the neck. Once we have a mobile neck that is not locked from cranium, which is mouth, then now we have a chance of saying, let's activate the keys and get that vomer to shift things, not a minute sooner. And that's why I need to come out there, you can show you. in real time. When is the time to activate the key? And there's a rhyme and a reason. I'm working on metrics that patients can use at home and you in the clinic, like numerically, from nasal breathing to cardiovascular heart rate variability to other metrics. We need to wire the patient with some objectives that tells us we're in the right direction. Because if the metrics are not adding up, I don't care about your opinion or my opinion for that matter. Kinesiology test is great, but there's bias to it. It took me 4 years to master it, but getting a kinesiology test to work for you, it's also subjective. I want definitive stuff. I know I'm getting a little wordy, but here I just really want to make sure that you understand what the goal is. It's not expansion, it's cranial alignment. That's what the new appliances, and by the way, we're renaming it. What it is, I don't know yet, but we're basically using an oral appliance that's going to structurally change the cranium. Isn't that exciting? Like, you're not expanding anything. Like, this is, as sometimes all it takes is 3 or 4 turns. If you do all these steps 3 or 4 times, Rashida, I am not kidding you. I've had basilar invagination that patient is getting up and walking and their symptoms are just dropping. Not expansion. We don't need expansion. We just need the body to unwind, and that unwinding process is more important than what you. And honestly, most average patients need AP development. They just need like the lateral aspects of things. It's not as difficult. You know, you can always turn it, appliance. And if you produce the forces and you have not aligned the body first, guess where those forces will go? Not to the universe. It goes into the system, in a closed system, into the alveolar socket so the teeth get pushed out. This is why dentists are not getting the results. They don't understand, Dora. They don't understand the frequencies that we're producing, where they're supposed to go. They have no direction. They're like, oh, we're going to get you home fast. Okay, where is home? I don't know, but we're going to get there fast. That's really where the mode of operation is. And with her, the 2 other things that I want to make sure we address, again, I keep going back why I keep telling you, make sure you work with a chiropractor. Let's identify, give her the appliance, but caution her. It can potentially cause more hurt if the neck stays locked up the way it is. We have got to work with someone who knows how to work the spine, work the pelvis. The angle of the measurement of the cranial base to the length of the jaw. So she's got a vertical growth attained. So the jaw is postured forward only because she's trying to get that closure where the neck has to stay where it is for this airway to look artificially so good. So I want to make sure that, yeah, she definitely has a long face. I put the bare minimum amount of block in there. And once I kind of meet you in person, I will give you a few more pointers as to where to position the mandible. It's not bite, it's the mandibular alignment, interarch relationship. Those 2 terms I use. Mandibular alignment is more about where is mandible physiologically allowing all the structures in the neck to properly function. So we're fixing that relationship. And then where is the maxilla wanting to meet the mandible? And if those 2 are not in agreement, we first fix the mandibular alignment position by changing the occiput and the cervical spine in the cerebellum. And then we develop the arch with the upper appliance and allow the mandible to meet maxilla in a more neutral position. Not the teeth. We're not involving the teeth. Honestly, the work I do on the teeth is so limited. I have done hundreds of cases, maybe 1 or 2 orthodontics, only because they want straight teeth. I just don't do any orthodontics. When they are symptom-free, the maximal intercuspation should not cause damage. Teeth should not be referencing the body incorrectly. And I never needed to, unless they want pretty teeth. Like, oh, I don't want that crookedness, but your symptoms are done. Like, your body used your teeth for a good purpose, not for harming you. That's just my only 2 cents. That I know a lot of times we're dentists, we just want the teeth to touch. As a matter of fact, within 6 weeks of wearing the upper appliance, I want you to see this case unfold. And when it's in that stage, I probably would be there to kind of hold your hand through it. You will see the teeth no longer touch. It's like, oh my gosh, what am I going to do? Pop a champagne, I would say, because the teeth no longer are referencing the body. When the teeth are no longer, body is no longer insisting on the teeth to go back to that pathological intercuspation, that's when things are really moving in the right direction. That's the goal, to get them there and allow to unwind the system and then drop the teeth into a neutral position. Because right now she's locked into a pathology, locked with the teeth. Every time she swallows, she's locked and repeating that pathology in her brain. Breaking that occlusion, I don't think that your patient will understand any of this. So the first part is, I'm going to just, if you want to just explain to them the details, yes, she definitely needs more room in the mouth because she's in a full-on exhalation mode in the mouth. She's in an extension. Instead of flexion, she's in an extension. So caution, if she has a narrow sternal angle here in the rib cage, as we are doing that, we need to make sure that, that this is why I told you, you need the professionals. You're very key in her treatment to increase that oral space and tongue, absolutely. But we want to make sure she can use the rib cage. Otherwise, she cannot decompress here and here together. I'm not sure if I'm making sense right now. But we need to be at least another 10 millimeters. So she needs a lot of oral development in all pitch, roll, and yaw directions, but cranial neutrality is what we're focusing on. And alignment, obviously. So 22 at the bone level. So I am more affirmed. I have seen one other case like this patient was, oh my gosh, late 50, mid to late 50. She was a functional medicine doctor, naturopath. And we had achieved amazing results with it. And the tongue release was done at the right time. But for her, it was a birth trauma. We had to deal with that level. I mean, this resembled that to the T. We had a lot of emotional birth trauma. We had to she had to go and deal with specialists in that area. So I know this is a lot. Out of the gate, none of this would be an issue. We're just going to start with the phase 1, getting that mandible aligned, getting that nose to work, and let's see how the body responds. But it's super important for this patient. If I were to get a physical complexity of this patient, she's about a 9 out of 10. If you don't work with a chiropractor, if you work with a chiropractor and neuroreflexes specialist, she's a very easy case, totally easy case. But if you were to go in it by yourself, you know what I'm saying? With that neck posture, you will get results and halt. Like it would be 2 step forward, 3 step back, 2 step forward, 3 step back. And I don't want that to be you. I want you to move this case within 6 months, be like, whoa, this is amazing. Like, I love what I'm seeing. 3 months, honestly, with the right chiropractor, as soon as you start mobilizing the maxilla and the tongue training comes in, this kid is going to feel 100% better. The other thing that I really would like to have standardized way of taking the CBCT. And again, when you're here in Colorado or when I'm over there in Dubai, I want to go over is making sure that the standardized way of taking CBCT, how we stand the patient and take it, obviously nothing between their teeth. In exhalation position, so have them swallow twice, breathe through their nose with eyes closed in a stand position. So when you have the patient stand up, have them bite down, close their eyes, swallow, breathe through their nose, and let's see where the head goes. Okay, this is where the head ends up. Bring the machine to them. Don't shift the neck. And do not put anything in their mouth, because whatever that position is attained in the cervical spine, you do not want to miss it. So this right here, it tells, I knew already that the atlas to occiput position is going to be something we need to talk about, and that's the CT scan to show that. We already talked about this one. Again, there's not much of a value from this angle because the teeth are apart. I would love a maximal intercuspation, so I put it in there after I aligned the temporal bones, but it wasn't as valuable as I wanted it to be, but I still put in information that could be valuable for you and potentially a chiropractor. This is C2, Dr. Rashida, and here's the airway. Okay, so the right is left. Oh, so let me just write down here. So left is right and right is left. Obviously, you know that. I just want to make sure. So you see how the airway orientation of the mouth and the neck, it's smaller on the left side. Okay, let me remind you again. Again, it's written all over her face and mouth. So when looking over here, she's using one side of the body. She can clear the air from one side, but not the other. So she's overusing the one side of the airway. So the side of the airway that works is the right side, which works on the left side of the face. I know I'm not expecting you to understand what this is because we have a pump that works from bottom up, the diaphragm. So how we clear the air from this chest developmentally affects this side of the face. Okay, all to come later. But when I'm looking in here, I'm like, well, the right side of the face is not underdeveloped. So I would expect, structurally speaking, the left side of the airway to not. And it's exactly that. Pattern. She needs to get out of this pattern. She's stuck in one side. So she doesn't know how to reference and decompress herself from ground up on one side. This is why you need to work with professionals in physical medicine. And we're going to train them all for you. I mean, I would tell you what my preferred ones are in PT and chiropractor and see if you can find them right away for you. But PT, PRIs are well more verse trained to some degree, so they can actually reference using how to use the rib cage, because she needs to use both sides of the airway properly. And with the head position like that, she's not. Again, you changing the position of the mouth is tremendous. I don't know what you guys cover in ECMO. I would love to see who the speakers are, if they're talking about any of this. Dr. What's her name from Canada? She's a part of ECMO. You need to spell her name for me. She's from Canada. She's escaping me right now.
From Canada.
Yeah, she's huge with ECMO. She was in a women's conference, and with my upper cervical chiropractor, she said,
Yeah. Dr. Tamari. Dr.
Tamari, hi.
Tamari.
Yeah, she goes, you need to come and bring this to ECMO.
Yeah, hi.
The reason why I'm saying is because I don't think that they teach this at ECMO, or they do, I don't know, but where the neck is oriented. I'm not talking about the size of the airway. I'm talking about the neck orientation to the rib cage. Uber important. It's not about the size, it's about which side collapses. If I put air through the system and pull it fast, which side is going to shut down faster? Collapsibility, arousal, drainage, all of those combined. And I notice it's right over here. I think this is a mid-sagittal birth, deficit, spinal bifida, I guess. And when there's one, my upper cervical chiropractor told me if there's one, there's multiple. Tongue tightness, I'm gonna have to say it's an extension. It's the tube that doesn't come completely to a closure properly. It's just seeing the sign of that. This is basically the occiput. I just look at the orientation. There's a lot of constrictions in the mouth that we need to kind of open up with we address as we stimulate the palatine, premaxilla and maxilla complex with the appliance. A lot of this would be addressed. So I have a picture of the hamular notch. Again, I'm not trusting this because when the mouth is open, the hamular notch position changes. Still, I can see that the right side is on the lower side and left side in the higher side. So again, some of these pictures, I put it in there because it's a part of my workflow. I could not see the position of the condyle within fossa. I can tell you that in an open position, she's got lack of superior joint space. So whether the disc is slipping off, if the condyles are overseated, I have no way of knowing that because this was not giving me that information. The one thing that I referenced here, again, this is something I wanted to speak with mom and ask about birth trauma. This is the sphinobasilar joint, and I see an atrophy of that area. You see that right there? And there's like, these are things that I don't usually see in a CT scan right there. So I think there's a bit of there's some congenital defect per se in the SBS. She's super hyperflex. Whether there's a vertical disposition of that joint, but this is something that I would like to have someone more expert than me to looking into, because this clevis angle and how the palate is related to the C2, this is all chiropractic triangle. Again, it did not prevent me from getting this child a help, but the appliance you have in your hand is not going to be at the full functioning neutrality and arch development for a while until we get all of these alignments under control. And the most important of which is, where is the pitch? You can appreciate the pitch on the maxilla, how that palate is relating to the base of the skull, to the foramen magnum, and where is the dents. I don't think there's any upper cervical like dents kind of like impinging on the spinal cord, like the gosh, I need more coffee. The words are escaping me. The brainstem. That's what the word I'm looking for. The brainstem is sitting in this vicinity. So if any of these structures get jammed up, she's kind of sinking her skull sinking into. There's actually a syndrome associated. Skull sinking into the spine, upper cervical. A lot of things happen. Again, how much of this is birth? How much of it is attained later? Pattern-wise, we got to give that mandible a better reference, given that she's so vertical. Like I said, and I told Nader, I need to talk to Dr. Rashida. I want to make sure we have 1 or 2 chiropractors on our side working with this child. This is a lot of things you're trying to solve. The problem is right there. Am I making sense? I apologize if I'm just talking too fast. When I get to my thinking mode, this is another.
Some of the things, honestly, I'm not understanding. I think it's a bit
again,
complicated for me. But I think once I hear the recording 2-3 times, then then I'll be able to. Yeah.
This, you see this dent right there? That's, again, we're still in SBS. Remember I said I'm suspecting a vertical disposition right there. And I see this, sometimes the umbilical cord getting wrapped around the head and the occiput. By the way, when that happens, guess what traverses through this? Hypoglossal nerve. It's in that vicinity. controlling the tongue. You see how it's not about tongue tie anymore? Chances of this kid retaining some pure hair paralysis, some primitive reflexes is just rising by the minute. So if I were to say, who do we need to work with before we go to the arch development stage? SOT chiropractor, potentially an upper cervical atlas orthogonal at the second stage, not first. We can't move the atlas if things are not stable. Osteopath would be a great choice if they don't have access to either one of those, because she's still 20 years old and growing. Even so, I think osteopath, I just love working with them. And neuroreflexes, MNRI, motor nerve reflexes specialists. I will send you a website. You can just look into them global. I'm hoping you can find someone. Give them some exercises to just see if you can drop those reflexes, drop that manual brake in a car so we can go to neutral and fourth gear. I think she's retaining. And that's why, I mean, granted, again, I'm not judging any of that according to this, because there's something between the teeth. So is this much of a pitch is real in existence, and that goes out. Some of it is real, some of it is just, the intercuspation. Again, I keep tracking that down. You see that right there? There's that dent. This is supposed to be flush.
Doctor,
right there.
Can I ask you one thing? How much time do we have more of this? Because, I mean, you're going to take slightly more time. I don't mind that. I just that.
No. I just
can I reach home because I'm.
You know what? Actually, this is perfect timing because I also need to jump on a call in 3 minutes. I just want to make sure that the appliance you have in your hand, do not turn the keys on it. What you're going to achieve with it. First and foremost, when you put it in there, there's a block on one side. Make sure only first molars touch. She's able to attain a lip closure on it. If not, just shave a little bit off. And the fit, there's not much.
Okay.
I mean, I will probably get on a call with you with the patient when it's there, just to kind of walk you through it, just to make sure that you know what you're adjusting.
Okay.
And then get on finding the chiropractor first, because when she goes back home, I want to make sure we get on that first stage. Within the first 4 to 6 weeks, nothing much is going to happen other than setting the stage ready for the body to accept a treatment for the next 3 months. Just want to make sure you know that. Don't turn the key on it. You're not activating anything. We're just trying to see where the body wants that mandible to be, because this is the biggest part of this treatment, that cervical spine.
Right.
So, I mean, I think I drove the message home. Otherwise, I think you, as a matter of fact, unilateral bite block system has been amazing and tremendous, and that's what's embedded in the lower appliance anyway. So starting very slow with her and working on the first 4 to 6 weeks, just habit correction, reflex integration, nasal breathing, alignment, period. Set the stage. And by the time you come down,
she has to wear the lower appliance at night and the upper during the day?
Right. No. Upper at night, lower during the day. But if she cannot, if she's not stable enough to handle that, I would have to wear 2 nights out of the week, wear the upper, 1 night out of the week, wear the lower, like that. Interchange. I would like them
at night.
Yes, at night.
Okay.
And making sure she can breathe through her nose. So working on anti-inflammatory nasal hygiene, tongue posture, all that 9 yards.
Okay.
Yeah. I know.
Sure.
This is one of the reasons Nader goes, Bahar, you got to come down here sooner. I'm like, okay, but at least you guys are coming down to me, which I will have more chance. I have patients here. You can see me in action. That's tremendous. I will make sure that I can solid time with you and Dr. Jocelyn when you're here. But I think we can make this really beautifully work. Dr. Rashida, thank you so much for being patient, working this process. But you're lovely.
Thank you so much. Thank you for your time, and you're fabulous. Like really.
Oh my gosh.
Sometimes I'm like, I think I've never had this much of information ever. Like really, I'm not even kidding.
Did I mention buckle up? I mean, we're going out there. We're going to enjoy the ride. We're going to be about 250 miles an hour, but you will next year from now, you're going to be bringing the patients to me and telling me all of this. Hey.
Yeah, sure. I actually have 3 more patients lined up already. So I'm like literally just waiting for this patient to start and to see how it goes. And then, once I get that confidence, I will.
Do me a favor and I'll let you go. Go ahead and ask Nader where we can take the CT scan and make sure. I'll send you a video. Follow the instructions. The CT scan is the most important. If you can get your records, bring them to me here. We'll look at them. And I'm going to have to come out there sooner. I mean, this would be a lot easier if I'm in person explaining it to you. But I'll let you
Yes,
know. I'll let you
exactly.
know if it's all as well. I'll send you an email with the link for this one and the last one, and a few other instructional videos that might be helpful to you. If you have a question, email, let me know, and I can always get on a call with you as well if you need it. All right.
Perfect. Thank you so much, Doc.
You're
Thank
welcome. Have
you.
a good evening.
Have a nice
Bye,
evening.
bye, Dr. Rashida.
Thank you. Have a nice day.